Hey, good afternoon, everybody. This is Jason Weller with the Michigan Coalition Against Homelessness. Hopefully you are here to join us this afternoon for the Housing is Healthcare webinar, an introduction to sector collaboration and systems alignment. We are joined by Rockstar panel. But before we get into that, couple of housekeeping things. We like to assume that most folks who join us on webinars these days are familiar with the format, but we're always surprised by the folks who have different issues. So a couple of basic housekeeping things. First off, if you're having any issues with the audio or the video, that is beyond our control and is in all likelihood your connection with GoToWebinar. So unfortunately, the best and easiest thing to do is log out, log back in. 99.9% of the time, that's going to fix whatever the problem is. But we have absolutely no control over those things from our end. There are a couple of handouts. So if with your control panel that's on the top right hand of your screen, there's a couple of important features there. In terms of the handouts, should be a little orange icon next to handouts. Click on that and a couple of documents will show up underneath it. Feel free to download those. We have the presentation, two of the presentations that our guest panelists will be covering here in the first hour. And then we also have the RFP that Eric will be going through after that. So we kind of purposely split the three of those things up. So feel free to download each of those if that's something that would be of interest to you. We are going to hold questions until the end, but if you do have questions, this is a fairly decent sized group, so rather than trying to play the game of unmuting everybody's microphone and creating chaos, our preferred thing to do is have you use the control panel, again, top right hand side of the screen, and click on the questions box. And once you click on that little icon next to questions, the box will pop up and then you can type your question in there, and you can either share it publicly or you can share it with just us. But that's the preferred way we like to hear from folks. And also, if you are having any types of issues, either with the downloads or something like that, you can also let me know via questions and we'll see what we can do to help out. But otherwise, I think we're good to go. Before I hand things over to Eric, we do have a quick poll question just to get a sense of who is with us this afternoon. So please take a second and let us know kind of generally what sector you're employed in. And it's pretty straightforward. And I think we'll leave this poll open for a little bit because we're playing this game now where we have people logging in and trying to answer the poll question simultaneously. So we'll see how this works out. But I think we'll keep it open here for another 10 or 15 seconds. We always like doing this front-loaded polls because nobody started eating their lunch or doing other stuff, so a lot of folks end up responding. And we're up to almost 3/4 of you have responded at this point. I think we'll go ahead and close it out because that hasn't changed now for about 10 or 15 seconds. So not surprisingly, about 74% of you are in the homelessness or housing sector, 5% in healthcare, 21% in government, 11% in senior services, and 26% in others. So pretty good overall representation. So thank you for playing along. One of the few times I wish we could give out prizes, but unfortunately that's the downside of doing the webinars. So with that being done, I will now hand things over to Eric Hofnagel, who is the Executive Director here at the Michigan Coalition Against Homelessness, and we'll get things started.
Very good. Thank you, Jason. Welcome, everybody. Good afternoon to all of you. Glad to have you here on the webinar. This is a topic that our organization has been focusing on or talking about the last couple of years. We're stepping up our game a little bit and thinking in terms of what is the intersect of housing and homelessness, and more specifically in this particular instance, we are also wanting to bring to you some information that will help you have a better understanding of how cross-sector collaboration takes place, and systems alignment to help facilitate the work that you're doing in this area. So we're very pleased to have a couple of experts in the field, and I'll say experts in the field because they are more than 100 miles away from our office. But honestly, these are a couple of individuals who have some great information to share with you. We hope that this is helpful to you. And to move things along, we have a lot of information that's going to be packed in a relatively short period of time. I want to move right into an introduction, a brief introduction. Mike Kaprowski with the National Low Income Housing Coalition is here. He's going to be doing a self-introduction, as is our second speaker as well. But why don't you kick us off, Mike, and lead us down the path of the righteous?
That might be above my pay grade a little bit, the path of the righteous, but I'll do my best. Well, hi everyone. This is Mike Kaprowski. I am the National Director of the Opportunity Starts at Home campaign. I work at the National Low Income Housing Coalition. Opportunity Starts at Home is a campaign of the National Low Income Housing Coalition and several other partners. I've been in housing advocacy for a few years. Before housing, I was in the education space for a while, so certainly have seen the connection between housing and education. And then before that was a military officer. So excited to talk to you all today about Opportunity Starts at Home. So if we could go to the next slide. So Opportunity Starts at Home. What we're trying to do with this campaign is to build a broad national movement that generates support for federal policies that expand affordable housing for the lowest income people. Affordable housing campaigns are not new, of course, but what's unprecedented and what we think is transformative about this campaign is the diversity of the voices that we are bringing to the table to help us advocate for policy change. And of course, this is happening at a very critical time. 75% of you are in the housing homelessness space, so you know that the housing affordability crisis has reached really disastrous levels. It's most negatively impacting the lowest income people. I think housing advocates are realizing that we need help in making the case to the public and to policymakers that we need greater investments in affordable housing. We need more ambitious solutions to solve this problem. So we need help. We need the cavalry to come on in. And then at the same time, there's this growing recognition in other sectors, whether it's healthcare or education or criminal justice or food security. There's this recognition that they can't accomplish their own goals if the people they serve don't have access to safe, decent, affordable housing. And there's been some recent research over the past number of years that has helped raise this awareness of just how central housing is. So this campaign is really about effectuating policy change at the federal level and bringing in unusual suspects to help us do that. Next slide. So we started about a year ago by building this. This is our steering committee. It's kind of like our governance board, so to speak. And it's really unprecedented. It's a housing policy campaign, and yet most of the organizations that are leading it are not housing organizations, and that's by design. And again, the research is very clear that the impacts of the housing crisis are spilling over into many other sectors. It's not just health. There are impacts in terms of education outcomes. There are spillover effects in terms of people's ability to climb the economic ladder. Housing is connected to growing the economy and reducing crime and improving food security. And so this campaign is a recognition that we all have a stake in solving this problem, and that we're going to need a diverse range of people to work on federal housing policy change. So next slide. The steering committee that I mentioned earlier kind of functions like our governance board, but we've also created this, which is a bigger tent. We call it the round table. It's a little bit less time intensive. It's a little bit more flexible. We have representatives from about 75 organizations participating in the roundtable. They meet about 3 times per year in person. And, again, it's a lighter time commitment and there's more flexibility around it. And I'm going to talk about why that's important later, but you can see just the huge diversity of national organizations that are interested in housing policy change. It's very, very encouraging. Next slide. So we're taking all of these multi-sector partners and we're working to advance federal policy change. So earlier this year, we released our national policy agenda, which, these are the policies that we want Congress to enact. We've called it Within Reach. We've sent it up to the Hill. We've had a large congressional briefing. There are several offices that we're working with right now to introduce legislation that's aligned with these ideas. Next slide. And this is the policy agenda, the Cliff Notes version of it. You can see that our long-term goal is through federal housing policies to end homelessness and ensure that the lowest income people can afford rent. And we're going to get there through 3 policy strategies. We think that you need these 3 strategies in place. This is our vision of a robust federal response. And so long story short, you see those 3 buckets there. The way that I think about it is demand side, supply side, and prevention. And those 3 you really need in combination to solve the housing crisis. So the demand side is really about expanding rental assistance. So in this realm, you're talking about things like vouchers, renters tax credits, to bridge the gap between wages and rent. Supply side, this is just about increasing the stock of units. Here, we're really pushing on the National Housing Trust Fund. And then the prevention side, we are working with offices. We've built a proposal that for a new national program that would provide emergency housing assistance to people that are experiencing an unforeseen economic crisis. So this is about catching people earlier upstream before they spiral into eviction and homelessness. So, like half the country doesn't have enough emergency savings to cover an unexpected $400 expense. So if it's a broken down car or an unreimbursed medical bill or hours cut at their job, these are the things that are sending people down the spiral of eviction and homelessness. So this would be a new national program that would provide emergency assistance. Just makes a lot of sense, right? If you could provide somebody $300 a month for the next 5 months to help them stabilize in their current home, that's a heck of a lot cheaper than letting them fall into the spiral of eviction and homelessness and shelters, et cetera, et cetera. So these policy concepts it's a very encouraging time. We're seeing them manifest into actual bills. Elizabeth Warren has a big housing bill, Cory Booker, Kamala Harris, and there's several more that we know of that are coming down the pike. It's bipartisan too. So Senator Todd Young, who's a Republican from Indiana, has a bill that would create a bipartisan affordable housing task force in Congress. So we really think like there's a moment of opportunity for bold federal solutions, and it says something that 2020 presidential hopefuls feel compelled to put out a housing plan while they're running for president. That has not been the case for many, many generations. Next slide. I won't go too much into this, but this is just kind of our quick breakdown of we've broken our policy agenda into long-term, sort of the big asks, but we also have some short-term metrics, things that we think are achievable between now and 2020, and we've put some numbers behind that. And I can answer more about that if you all have any questions. Next slide. But the main thrust of this is that if we can achieve these housing policy solutions, we know that it'll improve outcomes in areas beyond housing alone, right? It's not just about fixing housing, it's bigger than that. So on our website, opportunityhome.org, we have what we call sector pages. It's one thing to say housing touches everything, but there is substantial empirical evidence to back this up. And we have fact sheets where we outline all the landmark research that shows how housing is connected to health and food and to economic mobility and to veterans and to education, criminal justice. So we've compiled all that landmark research and put them into downloadable fact sheets. I've gotten really good feedback about these pages, so when you get a chance, check those out. Next slide. So in the last couple minutes here, I want to just hit on, why even build multi-sector partnerships, right? There's a lot more I could say about the campaign, but I want to focus kind of on the lessons that we have learned in going through this process. That, we're a policy advocacy effort, but the lessons that we've learned, I think, are very generalizable to on-the-ground work as well. So, when you bring in multi-sector partners, I think one, it just really enriches your work. I'll give you one specific example. We were building this housing and health fact sheet. And I wrote the initial draft of it. I'm a housing advocate, so I did my best. And then I sent it out over to Allison, who you're going to hear from in a minute, who is in the healthcare field, and asked her, how should we think about this fact sheet? How am I doing on framing and messaging? And is this the right research to highlight? And Allison knew of very powerful research that was not known to me. She helped us incorporate messages and language that she knows will resonate in the healthcare sector. And so having these unusual suspects in our campaign has really helped enrich our content. It helps mainstream our communications so that non-housing experts can kind of understand what we're talking about. And we've done this process not just in the health space, but in the education space and all of the other sectors. So it's just so powerful to have, multi-sector partners on board. I think another thing that it's done for us is it has really piqued the interest of policymakers in ways that traditional housing groups can't do alone. When we meet with a policymaker and we're just a bunch of housing advocates, they already know what we're going to say. We're going to ask for increased resources in X, Y, and Z. But when we're shoulder to shoulder with Children's Health Watch or with the NAACP or with the National Education Association, it sends a very clear signal to policymakers that this is bigger than housing, that this is connected to a variety of issues, and that whatever their sort of pet issue is, housing is somehow connected to it. So it really, really creates a powerful team in that way. And then, in terms of on the ground work, you're better able to serve people, right? I mean, people's lives don't exist in a silo. Their day is a complex interaction of health and housing and economics and food and their neighborhood environment. No one sector can do this work alone. Next slide. So on the question of how do you build multi-sector partnerships, right? How do you bring in these folks into the mix? I think there's a couple lessons we've learned. First is to help bridge the connections with research. There is substantial research about how housing is connected to other sectors, but a lot of times, this research is unknown to other sectors. So for instance, education professionals, they might not be aware of the research that shows that low-income kids in affordable housing score better on tests than those in unaffordable housing. And so that's why we put together these fact sheets with hard numbers and infographics and the studies. That show people that success in their own field of work depends on whether people have access to good housing. So the research is our friend here. Two is I think you have to emphasize the mutual interdependencies. You got to get across to these non-housing sectors that their goals are advanced when we have better housing policies. That, for them to get involved in housing work, it's not a nice to have for them. It's a need to have for them, that their outcomes are so tied to what happens in the housing sector. I think you got to do some research on their language. There are a lot of language barriers between different sectors. So before we approach another sector, we spend a lot of time studying their language. We check out their websites and their videos and their reports. And to learn the language with which they speak and to use their own language when you explain to them the importance of housing. These language barriers are real, and so you got to kind of learn how they talk. And then the final thing is just be patient with them and have flexible entry points. And I'm going to go back to the round table that I talked about earlier, where it's kind of a flexible commitment. What we've learned is that, some organizations, they're going to be ready to rock and roll with you pretty quickly. And then others are going to be unsure how they approach this potential work, right? They're going to just want to dip their toes in the water and just sort of, go on a couple first dates. And that's okay. You can't expect non-housing organizations to sort of flip overnight to do housing work. And that's okay. And that's the roundtable for us has been a great structure to let people dip their toes in the water. And so think about how that applies to your own work in terms of, creating flexible entry points for folks that maybe haven't thought about housing a heck of a lot. And then the final slide is just the challenges. This is hard work. I think one of the challenges is the bandwidth of these multi-sector partners. So whether you're talking about education folks or healthcare folks, everybody's got their priority issues. They have limited bandwidth to expand their focus. They might understand and want to be supportive of your work, but they will have limited capacity to do it. And that's where you have to be prepared to shoulder the workload and, carry the weight on some of the heavy lifting. So in our context, that means building the first drafts of the fact sheets and doing the sign-on letters and emailing them with simple instructions when the time is right. Um, the lack of a common language I already talked about. You know, in housing we talk area median income. Anti-hunger folks talk about federal poverty level. Education folks talk about free and reduced price lunch. So these language barriers are serious, and you got to spend a lot of time working through them. Sectors are not monolithic, so you know it's not as simple as saying, "Oh, well, we just need to bring in the education sector into our mix." Well, there's pro-charter school folks, there's anti-charter school folks. There are different camps in all of these other sectors. And so you got to kind of be intentional about, okay, it's not just about bringing in one organization from a particular sector. You have to understand that there's a lot of different perspectives in these sectors. Same way that there's camps in the housing space, there's camps in every other sector too. So you got to be intentional about that. I think the lack of relationships across these silos is something to consider. You know, it's just sort of the nature of our work. We sort of, you know, we work in our silos. People in the same sector tend to flock together, and so there's just not a ton of relationships across different sectors, and so that takes some time and requires being intentional about building other relationships. And then you got to balance the weeds of what you do. You know, in our context, we can very easily get into the weeds about housing policy, and you can very quickly lose people in other sectors. So you got to make sure that you know you're not you know you're not too much in the weeds when you approach some of these other sectors to bring them into your work. So I'll end there, and hopefully that was a good overview. And I think Allison is going to dig a little bit deeper into how all this plays out.
Very good. Thanks a lot, Mike. And actually, you did a great job, and I do feel a little bit more righteous after that presentation. So
All
thank
right.
you for sharing that. Just want to point out, you know, there are some things that Mike is talking about that are national in scope because it's a national initiative, but those are things that do translate at the state level or even at the local level as well. So we're hoping that this is helpful to you and you're taking this information and wrapping your heads around it and thinking in terms of how it can relate at the local level in your own communities. So let's keep moving on. Allison Bovell Ammon is the Deputy Director of the Policy Strategy for Children's Health Watch. Very pleased to have her here as well. So Allison, I know you're going to introduce yourself. Why don't you go ahead and get things started?
Thank you. Thank you. I'm delighted to be here today. As Eric mentioned, I'm the Deputy Director of Policy Strategy for Children's Health Watch, and I also co-lead a couple of housing programs at Boston Medical Center that I'll be talking with you a little bit more about today. So you can go to the next slide. So I'll tell you a little bit about the work of Children's Health Watch and some of our research around housing instability and health. Mike mentioned briefly some of our work. And then I'll also talk you through 3 housing models that we're testing out here at Boston Medical Center and some of the opportunities and challenges that have arisen from those. Next slide. So Children's Health Watch is a network of pediatricians and public health researchers, and our mission is really to improve the health of children under the age of 4. So we focus on young children, infants and toddlers and their families by informing policies to address and alleviate economic hardships. Next slide. We do this by interviewing families in pediatric emergency rooms and primary care clinics in 5 U.S. cities, and we've collected data for about the past 20 years. On the next slide, you'll see we talk to families in this interview around their ability to afford basic needs, so food, housing, utilities, prescription medicines, medical care, child care, all the things that we know that families with children need in order to be healthy and stay healthy. We also ask them questions about their participation in federal or state assistance programs, and we ask questions about the child and the caregiver's physical mental health and the child's development. And so we are constantly looking at this data, analyzing this data in order to better understand both how economic hardships impact the health of and development of young children and their families, but also what policies and programs and interventions might be necessary in order to improve health outcomes for families with children. Next slide. And so we really think about, this slide got a little jumbled in the transitioning to a webinar, sorry about that. But we really sort of think about these kind of interlocking wheels, if you will. So, you know, our work really starts with research. We've also been doing a lot to integrate and work with groups on screening for economic hardships or social determinants of health, or also called health-related social needs in clinical settings, to really identify potential health hazards, to social-related health hazards to families. But then we also think about how those might impact the ability to connect systems and ultimately to change policy. And so I will say that Children's Health Watch is on the steering committee and one of the founding members of the Opportunity Starts at Home campaign as well. So next slide. So what our research has shown over and over again is that a stable home is a prescription for good health. Let's go to the next slide. One of the things that we've learned over the years is that when we look at this sort of iceberg of housing instability, homelessness is really what's on top. And homelessness is the thing that, you know, I think when people talk about a lack of affordable homes, that maybe is where our mind goes. And certainly there is research, there's a wealth of research, including our own, that shows that homelessness is really not good for any period of time for a young child. But we also know that sort of under the surface, there's a lot more going on, and that's really related to housing instability and all the sort of factors that place people at risk of homelessness. And of course, sort of some of the roots of the problem, even deeper, unaffordable housing, systemic racism, economic inequality are really sort of driving some of these things. And so we really are trying to think more holistically about the issue beyond just homelessness. And so the next slide is some recent research that we published in the Journal of Pediatrics. And the formatting on this slide got a little jumbled in the merger as well, but if you look at the paper, basically what we showed is that when we looked at housing instability, three different forms of housing instability. So we looked at families who were behind on rent, who were moving 2 or more times in a single year, or who had been homeless. And what we found is that all of those were related to adverse child and caregiver health outcomes. But what surprised us is that for many of the outcomes, being behind on rent or moving frequently was as bad, or in some cases worse, than the families who were experiencing homelessness. And so it really raised the alarm bells for us to say, we need to do more, not just to respond to homelessness after it happens, but to begin to go upstream to respond to families who are falling behind on rent, living in unaffordable housing, or moving frequently before they even hit homelessness, because it's impacting the health of their children and the health of the parents. Next slide. So we started to think more about what solutions might be possible. And Mike did a wonderful job of outlining some of the policy solutions, and so I won't go into those, but I do want to focus today on some of the solutions that we've been testing out and identifying around connecting systems across sectors in order to drive programmatic change and responses on a patient or a community level. Next slide. So Housing Prescriptions is Healthcare we launched 3 years ago, and it's a randomized control trial that we're here at Boston Medical Center, where we identify families who are at risk of homelessness, so who are moving frequently, who are behind on rent, who are relying on family or friends for a place to stay, or who are paying 50% or more of their income towards their housing. And those who are randomized to the intervention group receive a complex set of services tailored to their housing needs. So we have a partnership with a local a housing specialist, community-based organization called Project Hope. And so those families will receive intensive housing case management. We're working with a local community development corporation for financial counseling and benefit maximization services. We have a lawyer on our team who can either provide legal advice to the rest of the team, to the case manager, or can connect a family if they're in a court-involved eviction process to an attorney, a pro bono attorney. And then we also have a partnership with the Boston Housing Authority, who not only do we pay for an application specialist who can work directly with our families through the application process, help them overcome any barriers that they may face in that application process, but we also have some priority access on the wait list for some of the units within the Boston Housing Authority portfolio. And so all of this is really with the goal to prevent homelessness and to reduce housing instability, but also to improve health along the way. And so we do have a very sort of rigorous research component as a part of this. Families who are not in the intervention group still receive standard of care here at Boston Medical Center. They still are able to work with we have a family navigation community health worker program that's able to help people navigate these systems. And then we also provide them resources, referrals within the community. Next slide. So we recognize that we built this originally for families, but there was a great need among our adult patients in particular to improve their housing stability as a way to promote health among our adult primary care patients, particularly those who are using the highest amounts of healthcare services and who are at greatest risk of medical fragility. And so we replicated the model in adult medicine in our complex case management program. So this is a program that's actually a program of our accountable care organization, so a part of our health system that really identifies people who are at risk of using a lot of healthcare services or who are currently using an excessive number of healthcare services, and provides them a wraparound team. So they get a community health worker and an RN in addition to a primary care physician and a connection to any of the specialty services that the patient might need. But when the health system developed this model, what they realized is that a big component that they were lacking was the ability to connect patients to housing. That for many of the patients, as you can see here, when we looked originally at how many patients were enrolled in this, almost half of them were homeless. And so no matter what the community health worker or the RN or the primary care physician and the specialty physicians and clinicians on the care team were able to do, if a patient was living in a shelter, if a patient was bouncing back and forth, unable to, for instance, if they have congestive heart failure, as you can see here, about 50% of them have heart failure, unable to access a bathroom, which is important for treatment for that condition, regularly unable to store their medications properly and take them on a regular basis. Those sorts of basic things that we know that people need in order to manage chronic health conditions, but being homeless or being severely housing unstable prevents people from being able to do, was a significant barrier for our patients and health improvement. And so we replicated the housing prescriptions model from pediatrics into adult medicine. We partnered with specialists at elders living at home who had deep specialty in working with particularly single adults experiencing homelessness and housing instability, and continued to work with Boston Housing Authority. And so as you can see here, we started to see among patients who were working with this program that there was a decrease in inpatient stays. I will note that one of the key lessons that I think we've learned over the past year and a half that we've been running this program is that the patients that are most successful in this model have either have no substance use disorder or controlled substance use disorder and controlled severe mental health conditions. We have found that because this is a scattered site model where services continue to follow a patient after they are housed, but they're not necessarily on site, for some of those patients, with substance use disorder, this may not be a right fit for them. And so I do want to note that there are other permanent supportive housing programs available to those patients, and those are very important, but it may not be the right fit for patients. So I think when we're thinking about designing models that integrate healthcare and housing, it is important to think about not only the target population in terms of age and family composition, but also in terms of medical conditions, mental health, and behavioral health conditions. Next slide. So we're still in data collection and data reporting, but we've had qualitative. We've done some focus groups, and participants have reported that having someone working with them on their housing reduces stress. We've also heard the same thing from providers, that having the specialist on their team who's working with the patient specifically around housing greatly improves their ability to really practice at the top of their license and help people in the ways in which they are best able to, knowing that the housing piece is taken care of. And then we've also started to look at preliminary data around improved housing stability. And for our families in particular, we're starting to see some trends in reduced maternal anxiety. Next slide. And then the third model, I'll just briefly touch on, is another pediatrics model that we're running here at Boston Medical Center that's a little bit less intensive than housing prescriptions as healthcare, but is a co-location model with a local or regional housing organization that administers a number of housing programs here in Eastern Massachusetts, Metro Housing Boston. And this partnership was originally funded by the Commonwealth. We're actually that may be transitioning the funding model a little bit, but it was originally funded by the state in order to reduce family homelessness and respond to families who are at risk of eviction, try to stabilize them in their housing, and quickly get them access to a statewide resource we have here in Massachusetts called the Residential Assistance for Families in Transition, which can help families with rental arrearages or other costs associated with housing instability in order to stabilize them in their homes. And so we screen at Boston Medical Center across all of our primary care practices and in the emergency room and in newly starting in the inpatient wards for a number of social determinants of health, which we call THRIVE. And one of those social determinants is housing instability and homelessness. And so in pediatrics, when a family screens positive for housing instability and homelessness, it sort of flags it for the provider that they may be appropriate for a Metro Housing referral. And then there's a referral process through which the provider can use in order to connect someone to the person that comes from Metro Housing that comes on site to our hospital weekly to work with patients who will then follow up with them. And so she is a little bit of a lighter touch. She doesn't do as much intensive case management, but she really does try to work with families to start the process along the way of getting various forms of assistance that they may be eligible for, or doing housing search, or just sort of meeting the family where they are. I will say one of the things that's been really important about this model is it's really been able to increase the capacity and the knowledge of health providers who are working with families. So every other week, we have what's called housing case rounds, where all of the providers, so usually it's the community health workers, the family navigators, the social workers, the domestic violence advocates, all of people that are really working on health-related social needs with our patients and helping them navigate systems kind of come together, and we sort of workshop some of these cases. They can either ask questions to the Metro Housing specialist or to MLPB, formerly known as Medical Legal Partnership Boston. We have a lawyer on site who can also answer legal questions. But what we've learned through this is that it's in doing this exercise where people are able to bring case examples and sort of work through how might I help this family who is living in a unit that is overrun with cockroaches, and I'm not really sure how to navigate the system to help advocate for this family. having someone there who is an expert in this field and can help them through that process, then they're able to do it for the next family and the next family. And so we've really seen that this is an effective model, not only for responding directly to patient needs, but also improving the ability of our frontline staff to be able to effectively know where to send patients, referrals, and help them through these very complex processes. Next slide. So all of this is not without challenges. I will say referrals can be quite challenging. We're asking health providers to start to think about a different domain of their work in a new way, and being able to sort of know what resources are available and how to screen people and refer them to the proper resources. Of course, for all of these, sort of took a bit of a ramp up time. So I will say one of the perhaps biggest challenges, and I think this speaks to a lot of the things that Mike also laid out as challenges, is we're talking about sort of sectors and organizations that operate very, very differently, that have different languages, that have different data systems, they have different cultures. To start to think about how they can integrate or co-locate or at least work closely together really requires a lot of leadership on rethinking sort of service delivery, rethinking some of the systems and workflows that we may be used to, and really sort of engaging and being honest about sort of the culture and the ethos of an organization and how we might be able to work together to sort of to move patients along in a really concerted effort that is a unified drive. Obviously, funding is continues to be an issue. Many of these programs, even the ones that have some state funding, also have to be subsidized with philanthropic dollars. And so sort of continuing to think about how to fund this beyond just pilots is always a challenge. And then we also have done a lot and have learned a lot around the duplication of services. I think it is incredibly understandable that when someone is experiencing something as stressful as losing their housing or being homeless, that they will ask everyone that they talk to who is in some position of authority for help. And so what we've learned is that families often don't, it's not that they have zero providers helping them or zero case managers, they have multiple. And so being able to kind of understand the landscape of who's doing what, who's going to take which piece, and really, not creating wrong doors for people, but directing people in the right places for the right types of services so that we're not working either duplicating work or even worse, potentially providing information that kind of crosses each other. And then finally, of course, there's just a lack of affordable housing options for our patients here in the Boston area. That is also, as Mike mentioned before, a national problem as well. Next slide. So I think just really in sort of conclusion and thinking about the ways in which housing and health integration is possible, I think this is a big opportunity. We're in a big moment to promote health equity, and I'm so happy that so many people have joined this webinar to start to think about housing and healthcare partnerships, and thinking about the ways in which we might not only work together, but we might also sort of think about how our funding streams are either braided or blended, that everyone sort of is bringing something to the table, and then also sort of identifying ways to identify homelessness and housing instability within health systems, either through universal screeners or other sort of assessments, and then coordinating and integrating service deliveries across sectors. So thank you so much for listening. I'm hopeful that we'll have a time for a few questions, but I also, on the next slide, left my email address here if anyone has any follow-up questions that I don't get to today and would like to reach out. I'm happy to continue the conversation. So thank you.
Fantastic. Thank you, Allison. That was terrific. It was nice to see Mike look at kind of that macro view, national relationships, thinking about policy and advocacy work, collaborative work, cross-sectional or cross-sector collaboration. And then you bring it down to that local level with some examples of some specific programs at the community level. I think was terrific. What I'd like to do is open it up for questions. We do have enough time. We were budgeting, I think we got about 13 minutes that we had set aside yet for Q&A. So I believe that we're going to have people raise their hands or type in their question. Jason, what is the process that you'd like to pursue here?
So folks need to type in the question using the toolbar. And in fact, we already have, so the toolbar on the top right hand of the screen, looks like we have a handful of folks who are early adopters because they've been either asking questions or making comments as Mike and Allison were presenting. So we actually have a question all primed and ready to go, and this is from Leonard, and it regards medical legal partnerships. So Leonard makes the comment that medical legal partnerships has given their organization leads to families that need assistance, but our funders are very specific to how it relates to their goals. Can hospitals provide office space and partially fund a case manager position? We found that there may be a short-term program, but then the funding dries up and we have to abandon it. And I think he's wondering if, I'm guessing Allison in particular, but if Mike might also have any suggestions. He's looking for suggestions on how they might be able to navigate these waters.
Yeah, this is Allison. I definitely resonate with the I guess frustration of having short-term positions funded. I think the question around working with medical legal partnerships and case managers, one of the things that medical legal partnership here in Boston has, I mean, we are very fortunate at Boston Medical Center to have had a long time relationship with our medical legal partnership who's been on site for a while. But one of the things that they have shifted their model to be more focused on is less on the sort of direct forward-facing with the patient interactions and more on the education and capacity building among providers who are hopefully here for longer term than just a short-term, philanthropically funded grant. For instance, they do a lot of education with our family navigation teams, with our community health worker teams around here are some of the big legal issues that families facing housing instability or families with low incomes or families with complicated immigration status or just immigration statuses face. And here are some of the ways that you might be able to either direct someone to another resource or to troubleshoot with that person. And so one of the things that the legal team has done specifically on our intervention is a lot of times just sort of help people know what kind of language needs to be used. For instance, if you're talking with a landlord, how the best practices in doing that, those sorts of things. Obviously, without you're not the lawyer or the legal advocate for this person, but being able to sort of give someone the tools and the confidence to be able to deal with pretty complex issues, I think is one of the things that our MLPB has been focused on. I think is a really good model for kind of troubleshooting this issue around wanting to have something more long term, but recognizing that the funding may be shorter term.
Perfect. Thanks, Allison. Mike, do you have anything you would want to contribute as well?
Oh, sorry, I was on mute.
Oh, okay.
I was talking, but nothing was happening. No, Allison, that was perfect.
Okay. All right. And I see we've gotten another question that's very specific to the RFP, and I think we'll hold off and get into that once Mike and Allison's portion of the presentation is finished. So let's see. So it looks like we've covered everything related to Mike and Allison's portion. I guess we'll make a final call here for if folks have any questions that they want to direct towards them. Otherwise, I think we might be able to let them go.
Going once, going twice. See any other questions coming in, Jason?
No, it's all quiet.
Well, very good.
All right.
Well,
Thanks.
again, thank you, Mike. Thank you, Allison, for being here and participating in this webinar. We really appreciate you sharing the knowledge that you have. This is always helpful to get examples from other people who are actively doing the work. So appreciate your firsthand input on this. Thank you both very much, and we'll hopefully be working with you in the future.
Yeah, thanks for the
Thank you.
opportunity. Enjoyed it.
Take care.
Bye.
Okay, and for the folks that are staying on this webinar, the intent was to have that educational portion on the front end, followed by a review of our RFP and a discussion about our initiative that we're undertaking. So we want to jump right into that. And those of you who were not interested in staying for the information about the RFP or the initiative, you're welcome to leave if you'd like, or stick around to hear what we're going to be covering. But we're going to try to wrap this up in about a 30-minute time span, hopefully less if we can. But we will certainly have time for questions at the end, including the question that did come in earlier. Hopefully we can cover it in the presentation. If not, we'll answer the question separately at the end. So increasing health and housing outcomes through integrated systems sounds like a pretty interesting topic to me. And we've been talking about it, as I referenced earlier in the presentation. Within our organization, we've been talking about that. That's been kind of a hot topic around the state in different circles. And so we were fortunate to be able to receive a grant from the Michigan Health Endowment Fund to create a new initiative that would look at that intersection of housing and healthcare, and specifically targeting our aging population. So we're talking about individuals who are 55 years and older. So we'll spend about 30 minutes discussing the initiative and our open RFP that we have put out to select a participating pilot community to pursue this initiative. Next slide. So before we do that, I want to talk a little bit about some of the data. We have pulled together some information that relates to the aging population, seniors 55 and older. And I believe this was all taken, or a majority of it was taken from the annual data report that's developed by us through the Campaign to End Homelessness. So what we know in looking at last year's data, the last report, 2017, with respect to senior homelessness, Michigan saw a decrease in individuals experiencing homelessness for every demographic except for one demographic, and that's seniors age 55 and older. I don't know if most of you are aware of that, but we've been trending upward for the past few years. 82% were between the ages of 55 and 64 years old. With respect to health needs, we know that homelessness is known to create health needs. Similar to housed individuals who are 15 to 20 years older. Those are the kinds of issues that folks who are homeless typically are experiencing. So including geriatric conditions of premature death and chronic conditions like cardiovascular disease and cancer. And we know that nearly 3/4 of Michigan's homeless seniors self-reported a mental or physical disability or a substance use disorder. 3/4 of Michigan's homeless seniors self-reported those issues. Also, when we look at homelessness and healthcare, we think in terms of high utilization, and that's not limited to just seniors, of course. And so we're going to give some data here that was developed through the SIM project, the State Innovation Model project, and this is data that is not specific to seniors, but it does reflect similarly across all age groups. From October 1st, 2017, September 20th, 2018, homeless inpatient utilization, if you were combining Medicaid and fee-for-service, was 29 stays per 1,000 member months versus the state total, which was 8 per 1,000. So in essence, we're saying that people who were experiencing homelessness or housing instability had a 256% greater chance of utilizing services. Okay, so we can see the data that tells us if you're homeless or unstably housed, you're going to see an increase in the utilization of the services. The homeless emergency department visits, and that's combining Medicaid and fee-for-service, stays of 297 per 1,000 member months. The state total was only 71% for people who were stably housed. That's 319% greater chance of having an emergency department visit if you were unstably housed or homeless. Okay, so data is showing us that there is higher utilization associated with your housing instability. So looking at healthcare savings, the cost of healthcare can be greatly reduced when individuals are stably housed and provided supportive services. So we're looking at an estimated cost savings that offsets expenditures by between $9,000 and $30,000 per person per year. That's from some national studies that we haven't cited here. But just to put things into perspective, I think you understand that if you don't have proper housing, you are at risk of higher healthcare issues and higher utilization of services, and by extension, higher costs to the healthcare system. Next slide. So talking about our project specifically, we want to give you a little bit more background on that. This is a 6-month pilot project funded through the Michigan Health Endowment Fund, as I had mentioned earlier. And the intent is to establish partnerships between key community stakeholders for the purpose of establishing system linkages and improved health and housing outcomes for seniors age 55 and older who are experiencing literal homelessness. So what we will be doing, what we're bringing to the table through this grant after we've identified a community, is we'll be hiring a local consultant that'll be a lead person working in the targeted community. We will be working to develop a stakeholder table, much as Mike had mentioned, the round table, that kind of concept of having a large group of stakeholders together that come from housing and healthcare sectors sitting at the same table. We're then also looking at having 3 stakeholder convenings, which will be an opportunity for us to bring in some outside expertise and to try to educate stakeholders in that particular community relating to issues like cross-sector partnerships and thinking about intentional relationship building and looking at systems of care and trying to align them, etc. And then we're also going to be creating an intercept map to illustrate those linkages, to identify gaps that exist in that community, create space to discuss opportunities for improvement, etc. Next slide. Thank you. And so, at the end of the 6-month period, when we're thinking about what the outcome will be, we're expecting that the pilot community will have developed a strong stakeholder table with the opportunity for continued alignment. And why we say that is that we are looking at this as being a pilot that could continue on for more of an implementation period, which I'll talk about in a little bit. So having a strong stakeholder table would help to tee that up. We're talking about creating a shared vision for systems integration and a process for creating community level action plan, and then actually thinking in terms of creating a draft action plan for systems integration. So that community would go through that process. And we're also talking about obtaining a pledge of commitments from each stakeholder that would be participating in that roundtable to assist with data and resource sharing for that integrated case management. And so again, what we're talking about is having a 6-month pilot, kind of teeing things up if funding were to come through, for us to look at a 2-year implementation, again, based on available funding. If we're able to secure the funding that we think we will be able to, or be in a position to get, we would carry on a 2-year implementation process in that target community. Next slide. So we have an RFP that was out. There was a link that was shared earlier. Hopefully you had a chance to get that document and open it up and take a look at it. But I want to make sure that we kind of explain what we're envisioning here because it may not be as clear in looking at the RFP or the first time through it. So we want to walk through it and provide some clarification, put it into context. What we're looking for is a community that would be targeted, but within that community, we are hoping to identify a project host entity, an organization or an agency that would be in a position to actually submit the application. So rather than having a collaborative of 20 organizations submitting the proposal, there would be one agency or organization that would be the lead or project host entity that would be actually submitting it. That entity would be receiving a stipend of $10,000 during that 6-month period. And the idea there is that we're looking at having an entity that will help to take the lead on things and assist us and in essence, grease the wheels. That entity would be required to provide office space to the consultant that we will be hiring. They will assist with access to standard office resources. They will help to identify potential stakeholders in the community and to actually assist us in giving introductions to help facilitate our engagement with those stakeholders for the kind of outreach that we want to do with stakeholders, and then provide a historical and community context for the consultant to help them kind of understand the lay of the land, what's happened in the past, where are things now, what do things look like, so that the consultant will be better equipped to navigate between the systems while developing that intercept map that we talked about earlier. Next slide. So, talking about a community, how are we going to be selecting the community? Well, we would like to see a proposal that will help to illustrate the community's need and capacity. Okay, show that there is a need in the community for a target, this target population, and then also that there is a capacity. In essence, that there are enough people at the table who are saying, yeah, we're committed to this, we buy into this, we're going to be a part of this process. Okay, so we want to see that there's a high need among the number of individuals in the population of 55 and older who are homeless. We want a strong indication of interest from stakeholders, and we're looking at a broad group of stakeholders, including hospitals, healthcare providers, housing providers, aging population providers, consumers, and others. So the idea, again, that it's not just a couple of entities or organizations that are talking about this, but you can show that there's a diverse and strong commitment on the part of other partners or other stakeholders. Third, we're talking about an ability or an interest in linking public and private data. If there's an ability to do that, that is something that we think is really going to be essential in moving forward. And an example is HMIS data. If the Homeless Management Information System data and hospital claims data, for example, would be something that could be accessed and utilized at the individual level, thinking about individuals and their use of hospital services, et cetera. Those are the kinds of things that we would like to see that will enhance the chances of getting selected as a community. And then lastly, we're talking about a commitment to improving health and housing outcomes at the individual level by implementation of integrated case management. So is there an interest and a commitment on the part of partners to be exploring that option of integrating case management? Next slide. Okay, so with respect to the RFP, we are looking for letters of support. Again, we're wanting to make sure that there's a community that has buy-in and that we can see that, and it's not just in name only, but we can actually see that there are some partners who want to be at the table, and it doesn't have to be completely inclusive with 300 agencies providing letters of support. So what we're looking at here is at least one hospital or large healthcare provider or related collaborative body. So what we mean by that is, a hospital or healthcare providers may be participating in some type of a collaborative way at the local level now. So that body could be making the commitment to participate at the round table, or it could be an individual hospital or provider standing alone as an example of that buy-in. one aging population service provider, so area office on aging, et cetera. One homeless service provider or other collaborative body, meaning, could be the continuum of care versus a single service provider, and then a consumer, somebody from that target population. Sometimes this is a little bit more difficult to find, but we do think that there should be some buy-in from someone who may be in that age bracket, who has experienced homelessness, that would be able to bring that perspective to the table at that round table. Next slide, please. So just to make sure you're clear on the timeline, we're looking for the completed RFPs to be submitted no later than 5:00 p.m. on Friday, June 28th. So that's coming up here in a few weeks. Applicants would be notified no later than Monday, July 22nd of the decision, earlier if we're able to do that. But we will let communities know either way by July 22nd. The selected community will begin the 6-month initiative Monday, August 1st. So we're looking at it running from Monday, August 1st, concluding February 1st, 2020. So that 6-month period. So again, want to just touch on the fact that we are looking at additional funding opportunities, and we'll be seeking funding for an implementation phase. Again, we're targeting a 2-year implementation phase, but at this time we don't have that secured, so we don't want anybody as a community to be applying and assuming that if they're part of this pilot project that they would automatically be receiving additional resources to carry this forward for the next couple of years. That is our hope. We don't have a guarantee on it, but that certainly is our intent, and we think that it makes sense to have things teed up with the 6-month initiative and then move on with the two-year implementation phase. Okay, I think at this point I'm going to open it up for questions. We have a fair amount of time left in the time allotted in this webinar. So Jason, any questions that have come up? Did we answer the additional question that came up earlier?
Yeah, you just answered the question that came up about the opportunity to pursue additional funding through the Health Endowment Fund. So
Great.
no new questions have come in. So we're at a point where it's all clear.
Okay, well, I want to thank everybody for staying on this webinar for over an hour and hearing the educational piece, but also hearing about the initiative and the RFP itself. We tried to answer as much as we could through this webinar, but other questions may come to mind. Feel free to reach out to us if indeed you're looking at exploring submission for this project as a targeted community. We'd be more than happy to make sure we can clarify or provide input along the way. Certainly would hope that you and your communities would consider applying, looking forward to this project, and are excited about things moving forward. So I'm hoping for a large number of communities submitting. So again,
actually, we just did have a question come in. Okay. Somebody's looking for some clarity about how we define large, in quotes, healthcare providers in terms of number of patients or number of physicians. They already have partnerships with small local clinics, and so we're wondering if they need to have a large provider at the table.
That's a good question. Some of it will have to do with the size of your community, quite honestly. When we think about large in Grand Rapids, that is different than if we're talking about Gaylord. So I think that you have to use your judgment on that. And I would not think that we would be having a negative assessment by trying to, I guess, look too deep in the weeds with respect to counts of patients or physicians. I think that's for you to be able to decide that and what you think is larger, that you think relates to what we're looking for. That was a slippery way of saying that's not clearly defined, but I think you use your judgment on it based on where you are and what resources you think you have as far as providers. Any other questions?
That is it. So I think we're all good.
Great. Well, thank you all for participating. Thank you, Jason, for helping guide us through this process so aptly. And again, wish you all well. Hope that you do submit something, and do reach out to us if other questions come to mind.
All right. Goodbye, everybody. Have a great afternoon.
Take care.